On the screen, you have a scientific study that was published in 1995, and it was a pretty interesting study where they done in Japan, where they took healthy teeth and 19 pairs of intact healthy teeth. Now, you'd wonder how you get to do experiments on intact healthy teeth, but anyway, they drilled holes in half of them, and they did root canals on the other half. And then they went in to look and see if there was any bacterial invasion in the result. And there, as you might imagine, that there were between per square millimeter, there were 3 to 4 bacteria per square millimeter of dentin in the vital tooth that had a hole drilled in it, and it was left open for the period of the experiment. And on the tooth that had the root canal done by the graduate students in endodontics, there were 3,000 to 4,000 bacteria per square millimeter. And as a follow-up, the DNA testing showed that the bacteria are all manner of horrible pathogens. They're anaerobes, they produce exotoxins. It's just, the dentin is just chock full of pathogenic species. So when somebody says, well, I cleaned my tooth out with ozone, or I cleaned it out with a laser, or I cleaned it out with chlorine, the question is, and so are you doing that every day? Because it's like a tree in the forest. Is it, once that tree dies and it no longer has the sap and the circulation to keep bugs out of the bark or the tree fills up with organisms that are taking the tree back. And that same thing's true of a dead tooth. Regardless of what you put in the canal, the tooth itself is full of pathogenic microorganisms. But I just thought I'd share that with you because that's Boyd Haley's slide. Thank you, Boyd Haley. And you're going to hear more from Boyd later on this weekend. And so you've already seen that one, so now we need to go to the next one. Recent Perio PowerPoint. Slideshow start. So I promised you that we were going to get into some of the fun stuff of dentistry, and that 90% of the adult population have periodontal disease, and that is not our fault. That's infectious disease, and it's not an epidemic, it's a pandemic, and that means everybody has it. And when you do DNA testing, that you find that the bugs are either your mother's, your lover's, or the dog. So that, don't you love DNA testing? And Bowser, don't put your tongue on my face. So that the therapies that have been adopted for periodontal disease have changed remarkably in the last 50 years. In my grandfather's time and in the medical practices clear back in the 18th century, 19th century, they would paint the gums with stuff like ginseng violet or zinc chloride or silver nitrate to what they thought was, heal the gums, but basically they were killing bugs. And now we know that, bugs aren't that hard to kill. And so there are a lot of better ways to kill bugs. And so they will be talking about that. One of the people that I really appreciate for his courage and his willingness to reach out to the dental profession is a guy named Bob Barkley. Is that Dr. Barkley somehow, and I don't know how, was allowed to talk to an all-student assembly at the University of Missouri at Kansas City, where I was going to school. I was a freshman. And so this is like, the second month we were in school. And so Dr. Barkley was talking to the 400 and some odd students that were gathered there, and he talked about the caveman dentist and how the caveman Thor had found a rock that was kind of a curvaceous, and he called it his dentalese rock. And that when Zog came over with a terrible toothache, that Thor said, have a seat on my dentalese rock here. And then he picked a large rock up and he said, hey, isn't that a saber-toothed tiger? And when the guy looked over that way, he hit him up the side of the head with the rock, knocked 4 or 5 teeth out. And Bob says the only difference between Dr. Thor then and now is we usually get them one at a time. Prevention means that you identify the cause, treat it, and look and see if it's gone. Well, that sounds like an interesting concept. Who came up with that? Well, that would be somebody named W.D. Miller 100 years ago. W.D. also went to the same dental school as my granddad, and University of Pennsylvania, but he was about 20 years earlier. And he came up with the idea that tooth decay is an infectious disease. Some of the other people we'll be talking about are Charles C. Bass. Everybody knows the Bass brushing technique today, right? Anybody know? Hold your hand up if you don't know. Okay, hands went down real quick. Okay, we'll talk about it. Dr. Bass we'll get into his life story shortly, but important that Dr. Bass was an MD, not a dentist. Paul Keyes received a prize in 1960 as a researcher for the National Institute of Dental Research, and what was his prize for? His prize was for discovering the organisms that most likely cause tooth decay: Streptococcus mutans and a little bit Lactobacillus acidophilus. But so he was a well-respected, fantastic researcher until he also found the organisms that cause gum disease, and then he's an idiot. So WD stands for Willoughby Dayton Miller. He basically wrote the book about microorganisms of the human mouth, and that it hasn't changed much since. That they're still there, and that therapy should be aimed at improving the oral flora of the mouth as opposed to removing teeth, cutting off gums, drilling holes, stuffing mercury in, and that sort of stuff. Because you think Bob Barkley said dentistry is like a carpenter working in a house that's on fire, and so we just rebuild the kitchen and the garage burnt down, and we go over and rebuild the garage and there went the bedroom. So we just get our little carpenter tools out and go to work. And if you think about it, Bob was talking about when he went to dental school, he carried a fishing tackle box, and at the medical schools they carried a leather satchel with a stethoscope and a flashlight and a few other things. And so he said there was kind of a difference between the education that they received. One is like how you learned how to tie flies and cast gold and drill holes, and this is you learn how to figure out what's wrong with a person and fix it. So he was more of the idea that we should be looking at the biological aspects of human health as opposed to the mechanical aspects of how you catch fish or whatever. Charles Bass was the first person to carry a microscope west of the Mississippi. So it's quite a while back. He was the youngest dean of a medical school ever. I think he was 27 years old, became dean of Tulane School of Medicine. He began researching periodontal disease shortly after the turn of the century, and he kept trying to tell the American Dollar Association about it, but they weren't interested. They could care less, and they badmouthed him. So in PR, the way you address controversy is that you first denigrate the source of the information. Oh, that Dr. Bass, he's an idiot. He's a bad quack. He's the youngest man to ever be the dean of a medical school and knows how to use a microscope. So you denigrate the person, then you denigrate their information. He's not a dentist, he's a physician. What's he know about the mouth? He's all wrong. We know germs have nothing to do with gum disease. And then you cite authority. And besides, the ADA recommends that you use the Stillman's technique, which is where you brush down on the top teeth, up on the bottom teeth, because Dr. Stillman was a president of the American Dollar Association, and he knows how to stop tooth decay. Well, you'd think I was really mentally challenged if I was telling you the way you get dirt out from under your fingernails, you brush down on your finger, right? Well, that's what they were essentially saying. And, it worked about as good as brushing down on your fingers. It was a technique doomed to failure. And Bob Barkley went around talking about it and got everybody laughing. And one of the things that the fools can't stand is when people laugh at them. And so when everybody laughed at Dr. Barkley and brushing down on that, that's got to be the silliest thing ever. So in 1972, after Dr. Barkley made everybody laugh at them for a while, the ADA adopted both the Stillman and the Bass technique. So if you don't know what to do, say it's all good. So anyway, most dental schools now are at least teaching the students something about the Bass technique. What's interesting about the Bass technique is that Dr. Bass did not just come up with it. He wasn't just sitting in the bathtub one day and say, I think we ought to aim the brush at the gum. He did a whole series of experiments with dental floss, with the Bass brush, with an oral irrigator, with his microscope. He didn't come at this by looking at his mouth and seeing whether his gums were pink or bleed or not. He looked at the microorganisms that were present with a microscope. So he could evaluate within a matter of seconds whether this was effective or not. And that's how he came up with the idea that if you're going to go get the gook out of the gums, you got to put the toothbrush toward the gums. If you're going to get the brush in between the gums, you have to pull out. And he started with things like the Oral B60 and ground off about a third of it, and he pulled out 2/3 of the bristles and polished the ends and all that to create the Bass brush. I've just given you a copy of the Bass brush. It's made by one company in the United States. It's called POH, for Personal Oral Hygiene. How did they come to make that? Was that the owner of that company was a periodontist, a dentist in Tulsa, and he had contacted Dr. Bass and had learned from Dr. Bass that you need to be pointing the brush at the gum, and Dr. Bass was making his own brushes, and so he bought the equipment and started a toothbrush company so he could have brushes for his practice. And I buy these, and these are my gift to you. And they're about 50 cents a piece. They're not bad. And if you're the United States Navy, you can get them for 10 cents. But the reason that I give this to you is because unless you've done the Bass technique of brushing with the Bass brush, you have no idea what Dr. Bass was talking about. And I give this example is that if you were unemployed, say for instance the dental business went and kind of in the tank, and you decided you were going to read through the want ads, and here's they want somebody to lie on a bed of nails at the circus. And so you went to apply for the lying on the bed of nails job, and you got there and they had the bed, but it only had one nail. You wouldn't like that job. But if it had as many nails as an Oral B60, you could boogaloo on that. It wouldn't bother you a bit, because it has enough pressure points that it would support your body. Well, that's what Dr. Bass understood. You need to remove the pressure points on a brush so that when you aim it at the gums, the bristles will divide and go in between the teeth. So all of a sudden now you're brushing where you're arguing at patients about flossing. If you can see gook on somebody's teeth, it's not a floss problem. It's a brush problem, because the floss is only the last little bit of gook that's hidden in between the teeth, because you can brush away all visible plaque with a Bass technique of brushing. And I actually demonstrated that for one lady who was selling Rotodent. She said, "Oh, you can't do that." And I said, "Want to watch me?" I had a lady came into my practice one time from a periodontist in San Francisco, and she was looking for a good dentist, and had heard that there was something about my practice that might please her. And I was curious as to how she was controlling her plaque, because when you look at her teeth, she'd obviously had terrible periodontal disease at one point in time. But when I looked at her mouth, it was perfectly healthy. There's no bleeding gums. The gums were tight and snug, and teeth were solid, and the exposed roots were all polished and shiny and all that stuff. And she says, "Well, I use gum grooving." And I said, "Gum grooving? I don't believe I'm familiar with gum grooving." And so she immediately whipped a toothpick out of her pocket, broke it so that it was only about 3/4 of an inch long, and she took the tip of the toothpick and stuck it down in her gum and scraped around the neck of each tooth, got up in between the teeth and rubbed it. And she said, "Can you hear it squeak?" "I can." And she said, "You rub it till it squeaks." And she went around with that little piece of toothpick in her fingers around every single tooth in her head. And when you look in there, there was no plaque. When I looked at the microscope, there were no pathogenic microorganisms. So I say, if she can do it with a little stick of wood, then the rest of us are just whiners, because we have all sorts of nice tools. We don't have to use a little stick of wood. But there are handles that you can hold the toothpick with. if you like. Perioids is what they're called, or the back end of a gum brush. But that's not the problem. Plaque, visible plaque, is not what causes gum disease. And I'll show you a movie in just a little bit about what causes gum disease, and I'll tell you, they're all swimmers. They're fish. They're not marbles that sit still. They're fish that swim away when you try to get them. And you go, whoa, this is an alive microorganism. And it's smart. It actually organizes itself. It creates colonies. It creates the spirochete will actually create a spirochetal pump. And that it'll take some not very fast organism and say, hey, you, I want you to use it. And then they line up on it like a row, and then they beat in a rhythm so they can create a circulation. So when bacteria start building their own heart so they can eat more of you, you're in trouble. But the good news is it's fairly easy to kill them. One of the things that I'd like to show you is a historical perspective of this. This is not a new problem. The gum disease has been a problem for mankind for tens of thousands of years. And it's a microorganisms. And so here's a fellow that lived in the San Diego area, and that you can see that they ate a diet of acorn. And the acorns wear teeth down. And so you can see how the nose and the chin are coming together pretty good, and the teeth are worn out to smithereens. And when you look at the lower teeth, they're worn down to nubbins. You can see this in the center of each tooth. There's where the pulp canal has receded, and these teeth are probably vital. And but the teeth have basically worn down to smithereens. You can also see that the bone has left all the posterior teeth. And so when you're going around with the perioprobe, you're taking a sharp metal instrument, pushing it through an area of infection, and poking it down into the bone. That's called seeding the bone, so the disease goes on more rapidly and advances faster. It's really good for business. It's very bad if you wanted really to save the teeth. So I did a periodontal chart on every patient every year after we disinfected the gums. There's absolutely no reason to take a sharp metal instrument and poke at the gums when there's infection there. If you had an infected finger and you went to the doctor and she picked up a blunt needle and poked at the infection about 6 times, said, yep, that's a hole in your finger, all right, you'd get a new doctor. So bone loss is the problem. It's not really gum disease, it's bone disease. And so that's what that looks like with no skin. That's what it looks like with skin. And what's causing it are these little things here. If you look, they're wriggling and carrying on and having a good time. And that is basically a spirochete. There's a red blood cell in the center. We'll have a better view of this in a minute. This is a phase contrast microscope. These microorganisms are clear. So under a light microscope, you get kind of an idea. It looks like you got fuzzy stuff in your eyeballs or something. But that they are wrigglers. They look like snakes. And they're not the good ones. Anything that's benign is sitting still. And so if it's not sitting still, then you want to kill it. So it's not rocket science. This is that same guy that I was showing you earlier, that on the upper teeth that actually worn into the pulp canal. And the front teeth wear out faster than the back teeth. But the back teeth are lost more rapidly than the front teeth, and that's because of the bone. The density of the bone on the maxilla is less than the mandible, and so typically you lose the posterior maxillary first. And that, the reason for the excessive wear in these people was because they were eating stone ground acorns. And so there's a little bit of granite in the acorn that if you grind it up with a stone, and that's a real tough food to chew, and the vegetarian, though, it's very nice. Here's a tooth that was worn into the nerve and became non-vital. Here's the youngest skull I looked at. These are all in the Museum of Man in San Diego. Rose Tyson was kind enough to dig through the boxes in her office and show me some representative examples. And she first looked at this fellow's skeleton, and she said, it's a girl. And I said, well, it's a pretty ugly girl if it is. And then so she looked at the pelvis and she said, no, it's a man, but it's a little bitty guy. And he's only about 4 feet tall. And she looked at his bones, the femur, and she said, it looks like he was injured and became ill about age 12, and then got a little better and then worse, a little better and then worse, and then died. And she estimated his age at about 21. He had all 32 teeth, and you notice no orthodontics? You don't see any braces, do you? So the crooked teeth is a symptom of our fluoride exposure. In China, the only place we saw crooked teeth was in the high fluoride area. All the kids in the non-fluoride area had perfect rows of straight teeth, all 32, if they were 18 or older. And so when the dentists say, oh, I haven't noticed any problem with fluoridation, you say, have you noticed that there's an orthodontist on every corner? And what's that got to do with it? And so anyway, when you took the skull apart and looked at the maxilla, you can see that the one side is extremely worn and the other side is not. And so we examined this a little more carefully and noticed that there was an abscess, a pretty good substantial abscess, where he'd worn into the pulp. And that if you look and see why he only ate on one side, is that the TMJ was actually fused to the socket on the contralateral side. And so he apparently injured his jaw when he was 12 and then couldn't eat. It only ate by gnawing, and that when he wore out that tooth, he starved to death. So teeth are a measure of longevity in many ways, and that fortunately now that we have McDonald's, we can eat with our lips. We no longer need teeth. In that same tribe, there was the fellow that lived to be the old man in the tribe, and you consider this is 500 years ago with no medical treatment except for the guy with the feathers and the chanting. Pretty good age to live to be 60, and average life expectancy in Europe at the time was in the 30s. So, and so we started looking at this specimen that I asked her. I said, "Did you clean this guy's teeth or something?" She said, "No, this is just like we found it, except we wrote San Diego Museum 16718 to be able to identify where it came from." And I said, "What can you tell me about it?" She says, "Well, see how the front teeth don't completely touch on the lower?" She says, that means that he was using those teeth to either strip a reed to weave it into a basket, or to make an arrow, use the leather to make an arrowhead. And I said, I'm going to vote for basket. The reason being is, see how shiny the teeth are? Is that business wasn't that good. So he would sit there with his little wooden stick and stick in between his teeth. And that's how he got to be. If he'd had a crooked stick, he could have saved those back teeth. Because that nice lady from San Francisco I was telling you about in my practice that took the little piece of toothpick, she got back behind her second molar. So he could have probably saved those back teeth if he could have got back in there and got those all those little gook off his teeth. The fuzzy stuff on the teeth is not what causes gum disease, but it is part of what allows gum disease to progress, because it coats the gums, gingiva, roots, and uses up the oxygen so that there's an anaerobic condition below that. And that's where the periodontal disease thrives. So it's not really this caused that and that caused this. It's they together in a sensation work to cause disease in your mouth. And the solution is to kill them. This is Del Mar man. They used to think he was 50,000 years old, but basically he was one of the jockeys there in Del Mar. About 5,000 years old. But he too had periodontal disease, and they dug him out of a sea bluff. No telling how he got there. Questions to ponder. Do you notice any orthodontic problems with humans from the past? Crooked teeth never existed. Occasionally you would get a caveman with a buccal version cuspid or a impacted wisdom tooth, but what do we got? 80% of the kids today can't get all their teeth in their mouth. That's a growth and development problem. And it's likely that growth and development problems may be associated with growth and development inhibitors such as fluoride, and that if you have growth and development problems with your teeth, do you have growth and development problems with your brain? Perhaps. So the present paradigm is that scaling, antibiotics, disinfectant, oral hygiene instruction, and surgery. And one of the things I learned from my mentor, Bob Barkley, is that if your oral hygiene instruction occurs in the presence of a pointing finger and the words should, ought to, and must, you are following into the role of the parent. And in the book, there's I'm okay, you're okay. It's called transactional analysis. And that as a doctor, when you put on a white coat, you fall into the parent role. And that the thing about parents is that if they can't see how fast you're driving, then you drive however fast you want to. Because the parental role requires reinforcement. And so if you want the kid home by 10, you got to be up there standing by the door at 10 and saying, are you in the door? And you should be home by 10. You must be home by 10. You ought to be home by 10. So that's the parent role. The trouble with the parent role is that it's never going to work for any great length of time. You know, your parents told you not to do that, and you're doing it. So that's what happens with parent roles. On the other hand, if you empower the patient to be successful or fail, then you are adult communication. And I'm not saying partner, you're not their friend, you're their advisor, and you are offering them a fork in the road. And what it is if I were you, and so the words might, can, able, empower the patient. I might look into getting rid of these microorganisms that are causing that problem, and then you turn it into a question. Is that the approach you'd like to take? And you got to get a yes before you go any further. If you can't get them to ask you how to do that, then you can't teach them. I'm serious. If you can't get, how do we get rid of these, then you're going to be beating them to death with dental floss. And I cannot tell you how many dental hygienists I would have to flog with the dental floss to make them quit beating my patients with dental floss. Maybe you don't remember, but the way you got into dental school was one of the things they did was give you a dexterity test. And so what they did is they selected kind of a unique group of individuals that have really good manual dexterity. And so somehow or another we've come to think that everybody should have that kind of skill. I'm sorry, I don't think it works that way. Is that some people have all thumbs and can't even get in their mouth. And you know that if you've ever tried to show anybody how to brush their teeth. Like, so that's what we have electric toothbrushes for. And that if we empower people to get rid of disease and become healthy, then all of a sudden they're a lot more willing to send people to your practice. They're a lot more willing to join because they don't want to be children. They don't want you wagging their finger at it. They don't want the hygienist yelling at them. They want to be empowered. They enjoy it. They seek it out. And that becomes a magnet to your practice. It became a magnet to mine. That was the engine that could. It just drove people from actually all over the United States into my practice. And I remember the beautiful 29-year-old lady. She's had a law degree. She's working toward becoming a partner in a downtown law firm. And she had already had surgery on her periodontal disease. She'd had gum disease since she was 17, she said, and she'd had surgery in her early 20s, and then the problem had come back. And the senior partner in the law firm was a patient of mine. And he basically told her, he said, if you're going to make it in this job, you're going to have to go get rid of that trench breath and go see Kennedy. And she came in, and she was easy. She was all spirochetes. And spirochetes are easy to kill. And, she said, how come nobody ever told me this? And I said, you ever see a dentist with a microscope? She said, no. And I said, they didn't know. So would you go fly with a blind pilot? You don't got a microscope, you don't know what's going on. And that's the key to Dr. Bass's technique, because he used his microscope to see what worked. And you need to use a microscope to see what works. And that you can get really cheap microscopes, so you can pick them up off the dime store. You can see stuff for $100. I bought a $300 microscope, sharper image. It'll take a digital picture. Pretty fuzzy, but I've seen it a million times, so I know what I'm looking at. But, honestly, $3,000 for a state-of-the-art Olympic microscope, phase contrast, not nothing. You're going to get that back on the first perioacacia tree. So, don't be a skinflint. So, consumer trends and desires, they're green, natural, integrative, self-administered, non-surgical, non-pharmaceutical, non-toxic. Isn't that what everybody's asking for? Well, that's what come to my practice for. I don't use, they say, One lady came in during the early AIDS epidemic, and she looked at me and she said, do you wash your gloves thoroughly between patients? And I said, no. I change them. so anyway, do I wash my gloves? Biological train is not the same as immunity. And it basically says, how do we achieve a terrain that's inhospitable to infection? And like I said, the bass brush is the riding lawnmower. Is it the first thing you do is you mow the grass? Drive all over that yard and all the tall grass is now short. Good. That doesn't get it done, but that's the start, because you got to get rid of all the weeds out of the way, because now what you got to do is get rid of the swimmers, and that's down underneath the gums. They have to have a decent amount of diet. You know, smokers always have more trouble than non-smokers. Those are habits. Stress management, grinding your teeth. You know, gnashing your teeth does not make them become loose. And you can prove that to yourself by going to any museum around, and you will see that the Native Americans had worn their teeth down to nubbins, and they were still fastened into their head. So if gnawing on acorns was going to make your teeth fall out, then they wouldn't have made it, would they? So it is a fallacy that bruxism or grinding your teeth is what's causing gum disease. On the other hand, if you put a mercury filling in a tooth, you lose a millimeter of bone within 12 months. So part of periodontal disease is the saturation of the jawbone. Remember when we did the sheep experiments? I'm sure they showed you some slides earlier. It saturated the jawbone with mercury. So now you have a compromised immune system around all your teeth. Will that ever go away? Oh, yeah, maybe. That would be with detoxification, and Boyd Haley's going to talk about a wonderful product called MBMI that seemed to be pretty good. You can have viruses causing gum disease. The herpes virus is particularly nasty about that. The bacteria are the primary cause. There is a parasite that moves in later stages, and if you've got amoebas and trichomonads, one or the other or both, then the advancement of the disease is quite rapid at that point. They are not causal. Dr. C.C. Bass wrote an article about amoebas and implicated in causation of periodontal disease clear back in 1913, and then he changed his mind. He said because they were not present in children and young adults who had early signs of periodontal disease, they cannot be the cause. It has to be something that was there when you were 10, 11, 12, if it's causal, and that's where you get the spirochetes and those organisms. So he changed his mind, but that doesn't mean you don't have to get rid of the amoebas. You need to get rid of them, but that's not the cause of the disease. That's just what's making it advance so rapidly. So back to my beautiful 29-year-old attorney and her dog breath. And so we took her through the program, and it was pretty simple. It was, she was about as easy as they get, about five visits of disinfection. And remember in dental school when they had you, you'd go through and you'd find somebody with periodontal disease, and then you'd set them up for a quadrant of scaling, and then you'd send them up for another quadrant of scaling. And I want you to go to the bathroom and just wipe half your rear. It's moderately insane, the things that they do in dental school, because you cannot clean a quarter of your rear. And I can guarantee you that the stuff in the mouth is more active than your rear. So the question comes to mind is, why did they teach us to clean a quarter of the rear at a time? And that is so that the instructor can look and see if you did a good job, because you're really slow and you don't know anything. So they want to be able to look. It's not a question of that's how you do it. That's a question of how they check it. So I had a terrible time. I had to flog my dental hygienist with dental floss a time or two, and then teach him to disinfect the entire mouth at every visit. So a cleaning, for example, starts off by flushing the gums out with a good bug killer, like chloramine T or iodine or salt and soda or ozone or any number of or oil of oregano. There's 100 different things you can use to kill germs. So you start by doing that, and when I had a new hygienist that didn't know what was going on, I told her, don't even bother to look at the microscope. I'll take care of that. I realize that that's stressful for you. because you've never seen this kind of thing. I interviewed probably 150 hygienists in my time. I only had one lady that knew that the spirochete was implicated in gum disease, and she'd never seen one live. She'd seen a picture. Well, the picture of a snake is not nearly as exciting as seeing about 5,000 of them, all trying to go north, south, east, and west at the same time. But I would say all I want you to do is that when you get through with the cleaning, I want you to take a sample and put it on a slide and let me look at it. And then I will break away and take a quick look and let you know where you're through with your cleaning. And we'd go over and I'd slop it on the microscope. And invariably, I had one lady who came from another office that was doing biological periodontal disease who could always produce a perfectly clean slide every time. Not one other hygienist was able to do that until after she'd worked in my office for about 2 days. And then they figured it out. You got to put this stuff on it and kill it. It's not a magic wand. You can't go by the top. You got to get down there and flush those gums out and kill them. And so when you do that, health results. The weight of the evidence points to the strong likelihood of entamoeba and gingivalis being the primary pathogenic pathogen with systemic manifestations in the destruction of periodontal disease. Who says that is a member of our academy, Trevor Lyon. And what happens is the amoeba is not locked into the gum. They live in the liver. They live in the jawbone. They live in the intestines. And so when you go after them, you have to go after them systemically as well as topically. I thought I could get them topically for years and years and years. And I basically found out that I couldn't. And Trevor basically started his lecture with an amoeba crawling across the screen, and then when it got all the way around the screen, it basically broke itself up into ate a bunch of white blood cells, and it broke itself up in a bunch of pieces, and all of a sudden we had a bunch more amoebas. So anyway, clever little devil. What do you kill bacteria with? You can kill it with soap, chloramine T, zinc chloride, hydrogen peroxide, iodine, ozone. I don't care what you kill it with. Matter of fact, the bacteria don't care what you kill it with. When you kill them, go over and look on the microscope. If they're all dead, nothing moves. It's really, really simple. But if you don't got a microscope, you don't ever know if you were successful. What else can you kill them with? You can use salt, you can use saline, you can use tooth and gum tonic, and Perio-Clear paste. You can use oil of oregano, tea tree oil, colloidal silver, aloe vera juice, and I don't know, belly. I don't know where belly is. Ozonated gas, water oil, bentonite clay. So there are lots of stuff that kill bacteria. Bacteria are not that hard to kill. So the idea is that what you want to do is you want to kill them. And so the most important point, you have to diagnose before you treat. And so Dr. Bass is sitting right here with a model showing you how to floss. And here's his toothbrush from the side. None of these bristles are parallel to one another. And so when you take that brush and cram it in your gums, it digs in between your teeth. What color do I want today? So whip a toothbrush out. Don't be shy. Aim it at a 45-degree into the gum and cram. If you got a little bow to the handle, about right, and jiggle. And you can just do this. If you can do that, and there's any red on the end of the toothbrush, you probably got a spirochete in there. The spirochetes live on fibrin and blood. And so if you can dig here as hard as you want to, this will rush, and nothing bleeds. It doesn't make your gums recede. It makes your gums well. So if you can be as vigorous as you want to with that, and you cannot hurt yourself with it. And so aim it at the gum, dig. Now, if you wanted to make it a nuclear-tipped weapon, you'd put 3 drops of iodine on there and then dig at it. Oh, well, now I've got a nuclear-tipped weapon. I'm doing better now. And so you can brush with saliva. I've got one. Cars come with a really nice toothbrush holder, and I got a little vent here on my Lexus. I have 2 or 3 colors there. Yes?
Could we go back 3 slides to the antimicrobial?
Oh, there's so many of them. Here's one. How about that?
Okay, that's fine.
The chlorhexidine is what's that? Paradex. It's a nice, expensive, what, $60 a bottle? I don't know what it is now, but it used to be about $60 a bottle. And that they did a survey of the prescriptions written for Paradex. Of the ones that were filled, only 40% of them were ever refilled. So Paradex tastes terrible, and you lose all your taste. So if you want to have you want to have a 60% failure rate, give them a terrible tasting soap to swish around in their mouth. But that doesn't even work that well. I got better ways. And so let me see if I can play a video for you. And where's my video gone? This is an animation of what you're about to see in this patient's bacterial smear. This is a white blood cell, your body's defense system. It's a neutrophil with a multi-segmented nucleus. The cytoplasm of the white blood cell appears to effervesce or boil. That characteristic distinguishes the white blood cell from the really bad actors, amoebas. In this smear, there's an army of white blood cells forming a barrier. White blood cells always work together to try to protect you, but they're helpless against the amoeba. This is a large amoeba. It is a one-celled animal and a parasite. It's often found in severe periodontal infections. It's about to give birth. This is the nucleus. The white spot is called a vacuole. The cytoplasm does not effervesce. They move by what's called a pseudopod, or in other words, this blob bulges out in one direction or another, and it slinks that direction. This one will take a nucleus and a cytoplasm and make a whole new amoeba. This is the only video I've seen of an amoeba giving birth. Spirochetes are virulent bacteria. Every species we know causes some terrible disease of mankind. Syphilis, Lyme's disease, ehrlichiosis, or gum disease, just to name a few. They move rapidly with a wriggling motion, which makes them easy to see on the microscope. They look like snakes. They can go in either direction, and unlike most other bacteria, they can bite. They can actually penetrate mucosa, and I've seen them bite their way inside a red blood cell. They live in the crevicular fluid around teeth and also in the bloodstream. They are a very bad bacteria to have, but fortunately they're easy to kill. They can't even stand oxygen because they're anaerobes. Salt or baking soda will kill them as well as a whole host of antiseptics. In my practice, I use the spirochete as a barometer of the patient's home care and also my own hygiene department. After a normal cleaning, both at home and in the office, there should be no active spirochetes. In the center of the screen, there are two skin cells, and between the two large cells is a white blood cell being attacked by a mass of spirochetes. Spirochetes show group intelligence and will actually attack your immune system. They have the ability to penetrate mucosa. This is called organization. When you see organization, you know the infection has been going on undisturbed for some time. Thus, home hygiene is inadequate. It usually takes several days for them to become organized. Spirochetes show group intelligence. You do not want smart bacteria. Here they have ganged up on a white blood cell. When you take the bacterial sample from the patient, you'll see thousands of spirochetes, all biting a white blood cell. This shows organization. When they get too crowded, they'll all line up on one of the non-motile rods and begin to beat together and make a heartbeat. So they create their own circulation and pack more spirochetes into a smaller area. This smear is almost to that level. When Trevor Lyon first lectured to this academy about the role of amoeba in periodontal disease, I was very impressed. On the following Monday, when I returned to my office, I met a new patient concerned about her rapidly advancing gum disease. What you will see is a short clip of the microscopic sample I took that day. This animation explains what you will be seeing. You recognize the amoeba and the white blood cell. The amoeba appears to stick a snorkel into the nucleus of the white blood cell, and almost immediately the nucleus appears to dissolve and migrate through the snorkel into the body of the amoeba. The white blood cell dies, but in doing so, it will release histamine, which will call millions more white blood cells to the area. More food for the amoeba.
Biocompatible perio is where you identify the cause of the problem and disinfect the mouth or kill a one-celled animal, amoeba or trichomonads. So it's a lifelong service as long as you don't become reinfected. So you get your mouth checked periodically and the mouths of your spouse and loved ones. So it's a human host pathogen. It goes from person to person. There's no surgery involved. It's merely a question of identifying the cause and killing it, and then making sure that it doesn't come back. It's a very simple, safe procedure. Strongly recommended.
This is a biological smear of a person who is infected with spirochetes, the little snake-looking bacteria. And this is a smear of a person who is effective in their oral hygiene. They have eliminated most, if not all, of the bacteria associated with disease. Is a trichomonad, a one-celled animal. Often found in severely infected periodontal pockets, it is also a sexually transmitted disease. Mr. Potato Head in the center of the screen is a very large and active one-celled animal, an amoeba. This is in a sea of spirochetes. And you can see some of the other organisms that cause disease also, spinning rods and small gliding rods. Non-motile organisms are thought to be harmless with the exception of Actinomyces accomitans. There is a large gathering of amoebas, 4, 5, 6, 7, 8. You see one moving on the lower left and many small gliding rods and spirochetes in the background. These amoebas are surrounded by a mat of white blood cells, as is often the case. They produce tremendous amounts of inflammation. The presence of amoeba in large quantities of white blood cells makes the classification of this disease as advanced as it gets. Here is an amoeba that wraps itself around a white blood cell, then grabs onto it and drags it with him. The white blood cell is damaged by that attack and begins to expand in the middle. Effervesce less, and the cytoplasm is almost entirely lost. In the smear also note the small gliding rods and spinning rods. They too are associated with inflammation and bone loss. The amoeba, moved by putting out pseudopods or false foots, then flowing in the pseudopod motion. Somehow he's grabbed onto this white blood cell and is taking it with him, perhaps for a snack later. These thin stick-like bacteria are called cytophaga or clock arms. They attach themselves at one end and spin around like the hands of a clock. This area shows an infection with large gliding rods. As you move around the bacterial smear, it will differ remarkably from place to space. You can also see some spirochetes in the background. Bacteria tend to grow up in nests or colonies, and this is one with large gliding rod as the predominant organism. The segmented rods are reproducing rapidly, so you know this is a fast-growing colony. Here are some very active large gliding rods. The white spot in the center is an air bubble. These are small gliding rods with white blood cells. Here are some spirochetes, again attacking a white blood cell. This is a skin cell on its side and white blood cells.
This is a smear of small gliding rods and spirochetes. This is a smear of what it looks like after pre-treatment and irrigation with chloramine T. Many agents can be used. This one is inexpensive, well tolerated, and rapidly lethal to almost all kinds of organisms, as long as you keep it out of sunlight. Sunlight destroys chloramine T, so you keep it in a brown bottle. The tools you'll need: normal cleaning setup with a mirror, Michigan Explorer and probe, and scalers. You'll need a glass slide with a cover slip. I've laid the probe and the tweezers beside them because these are what you'll use to make the bacterial sample. A good quality video microscope is essential in enlisting the patient's interest, cooperation, and compliance. I tell them when I take the sample, if it looks like the freeway at rush hour, then they need to kill it. If it looks like Death Valley on a hot day, you're okay. Here's the setup I use: tray, irrigation, ultrasonic. I'm sure you all have a favorite ultrasonic cleaner. They do a good to excellent job of dispersing the plaque, but first you have to kill the plaque. Just like a doctor should wash his hands before delivering babies, dentists are just now learning the importance of disinfecting the mouth prior to treatment. Easily done with subgingival irrigation. Any kind of water pick will do this. This is a heated Viajet, which is more comfortable for the patient. You'll need a cannula to adequately flush out the pockets. A cannula is a blunt tube with a hole in one or both sides. We bend the cannula about 45 degrees to make it a contraangle, like the perioprobe. Taking the biological sample is simple, yet critical to finding the infective organisms. Use the tweezers to milk a drop of fresh saliva from the floor of the patient's mouth. There are commercial slide prep solutions made of salt, but saliva is what the amoeba likes best, and you'll find better activity from the amoeba and the bacteria with just a drop of saliva. Take the Michigan probe or some very thin periodontal probe and gently probe the deepest pocket. Look at the x-rays if you have them to pick your spot. Do the four corners of the mouth is what I usually do. Like probing, insert the tip to the root, touch the root, and then tease out a sample of the bacteria and place it into the drop of saliva. Repeat this for each of the sites that you sample. Then press the cover slip down firmly and blot off the excess. Drop the sample onto the stage of any good video microscope at 400 power and voila. Be sure to include the patient in the visualization because this is the key motivational tool, self-interest. The first question out of their mouths is, how do we kill that? Which leads directly to the next thing you need to tell them. Home irrigation with an antiseptic. Not on a powerful setting, just thoroughly. While you're at the microscope, score the organisms and write down the kind and quantity. Be sure to include the white blood cells because they are a big risk factor for periodontal disease and infection. Also classify the patient. I use a category of 1 through 5, 5 being the highest risk of having had previous periodontal surgery. That accelerates the disease. And then their condition. A is for active, AR is at risk with some of the bad guys still present, and C is controlled. They don't get controlled until there are 3 sequential checkups 90 days apart with no bad guys seen. At that point, you've disinfected the mouth. At this time, also estimate how many visits it will take you or your hygienist to remove all these organisms and the tartar, or bacterial condominiums as I like to call them. We do a periodontal chart on every patient every year. That's why we date the latest one on the front of the chart and the treatment plan, so we can tell if they're due for another. Recall frequency for anyone with significant infection or pocket will be 90 days, as that's about how long it takes the bacteria to grow back once you've killed them. A cup of antiseptic in the irrigator, and I prefer chloramine T, but you can use anything as long as you take another sample at the end to be sure they've all died. Place the cannula just like you would to measure a periodontal pocket, 6 places around the buccal and lingual of each tooth. You need a vacuum close so the patient doesn't have to taste the solution too much. Just explain there are no yummy, sugar-tasting antiseptics that kill on contact. A foot controller is essential for using an irrigation tool. This is the smear we expect to see once the patient has been irrigated. Now you can begin to clean the whole mouth with the ultrasonic. It'll dislodge clumps of bacteria and tartar, and you can do this over the whole mouth at each visit. If a longer deep cleaning appointment with anesthesia is scheduled, one area may be numbed with local anesthetic, but it makes no sense to not disinfect and clean the whole mouth at each visit. Then we hand scale and root plane all the areas. Notice how I haven't said curette. We try very hard not to irritate the soft tissue. It is of no benefit, and it increases pain and delays healing. Then we polish, floss, and once more, a final irrigation. The next step is to verify. For new hygienists or skeptical patients, we routinely do a post-treatment smear. I've seldom had a brand new hygienist who could or would kill all the bacteria on the first try. But everyone was able to learn these skills within just a week. It's somewhat shocking how difficult these pesky bugs are to kill at first, but once you've learned how to do it, it's really no trouble at all.
Woohoo! So how was that? That's how everybody does it, right? I didn't know I needed a microscope. I was a jerk. I sat around and basically thought I could tell what was going on using my sharp stick, as Bill Landers talks about it. The ultimate bottom line is I couldn't. And my friend Jim Knott, big microscope guy in San Diego, brought over his father's 1930 Zeiss microscope, which was a major pain in the rear to use. It was just about like the student microscopes you had in dental school. You know how they're always out of focus and got crap on the lenses? Well, he brought that over and showed me how to set it up. And I looked at some of my successfully treated cases that I had done without a microscope. I wasn't successfully treating them. I didn't know that because I didn't have the other ingredient. I needed to be able to see if the bugs were gone. And that smear I showed you afterwards, there occasionally you may have noticed a little black Volkswagen driving through there. Those Volkswagens are hard to kill. And they'll be around longer than the spirochete or the other bugs. You will get them eventually, but I don't base the success on that anyway. I base it on, whether or not we can keep them down to a dull roar. But eventually you will get them all if you can get the patient at home irrigating on a regular basis. And that what I've been experimenting with in my own mouth, and I don't have any studies, there's stuff called shower flossers, where you can put a hose between the shower head and the building, and you can even use a little bottle and use a Venturi effect to squirt iodine around with it. And I made this video 20 years ago, and I have since gone away from chlorine. That chlorine in my movie that I gave you a postcard for, we talked to Bill Marcus about the pleasures of being a toxicologist at the EPA, and he said that one of the best jobs in the world for a toxicologist was to be an EPA toxicologist. Bill's talked to our academy. And he said one of the jobs he was assigned was to see if chlorine in the public drinking water was associated with breast cancer or prostate cancer. And he hired 10 separate research firms. He said, it's a great job. You got unlimited funds. So he hired 10 different firms and sent them out to look and see if there was a relationship between chlorine in the water supply and breast cancer and prostate cancer. And he said that a year later, when they all came back with their studies, they'd used different protocols and different procedures, but basically all valid means of measuring cancer and chlorine in the water supplies, mostly down in the southern parts of the United States, because it's warm down there and they have to really nuke the water with chlorine to keep it from smelling bad, among other things. And so that all 10 of them came out exactly the same. Yes, there is a relationship between chlorine in the water supply and breast cancer and prostate cancer. And so you see all these people wearing these little pink ribbons around saying, oh, we want to fight breast cancer, and men should be wearing little brown ribbons around saying we want to fight prostate cancer. And hell, they know the problem. It's the water. They just need to quit lying about the water. It's not safe to drink. It's probably fine for washing your car. It might be okay to irrigate with, but it's not safe to swallow it, because then your body has to detox all the trihalomethanes and all the other junk that's left over from having chlorine in the water supply. So when he talked about that in the movie, and I took chlorine and said, no, I think I'll set that aside for a really serious case where I have nothing else that'll work. But what is chloramine T? It's a chlorine molecule with ammonia, NH3, hooked onto it. Well, the end of a protein molecule has an NH3. It's called an amino acid, so it's got amino group on the end of it. So they take an amino group and hook it on chlorine, and you got chloramine T. They can take an amino group and hook it on iodine, and you got povidone iodine. Well, why is that important? Because when iodine has an ammonia group on it, bacteria actively absorb it. Because what are those bacteria doing? They're dissolving you, and they're absorbing your dissolved protein for their food. So when they see an ammonia group, they think, oh, that's food, and really it's a hand grenade. And so you can take, chloramine T was invented for what's called septic belly wounds, that in the Civil War, more than 1 million men died from being shot. And if you were gut shot, you were just done. Nobody survived, they didn't think, until one captain in the Union Army survived what they called a septic belly wound. It turned into a giant fulminating infection, it popped, and he survived. And so they thought that was so remarkable they wrote it up. And so the chances are 1 in a million are surviving, septic belly wounds. In World War I, what they would do is they'd open you up, find where the bullet went through, sew up the hole, take all the guts out and put them in a pan and wash them with chloramine T and put them back in. And they had, I think, 17% survival or something like that. It was infinitely better than the Civil War, but that was World War I. And by Vietnam and later, the survival rate was almost 80-90%. So if they didn't hit an artery and they could get you back to base, they could save you. So chloramine T is a one way, but povidone is a much safer way, and Lugol's is even safer. But my hygienist could show me germ-free post-treatment sample using salt water. We had canaries in my practice. I asked one lady one time why all of the environmentally sensitive people on the planet seemed to come in my practice. And she said it's because I didn't use mercury and I don't have any heat in my office. And I said, I got heat in my office. And she said, you do? Electric, but it wasn't very good. What do you want for $3,000? Anyway, I'm going to stop right here because I've covered what I wanted to cover. Did everybody understand that gum disease is an infection, you can kill it, and it's a real fun thing to do? And okay, good, because that was hey, I can shorten my lecture up to 15 minutes now.
That was a fantastic video. Is that available on YouTube?
Yep, it's on my YouTube channel. My YouTube channel is David Kennedy DDS, and it's called Biocompatible Perio. And that belongs to something else. And okay, he's going to put a code up for you, but I'm going to answer questions. Yes, please.
How do you know if you killed the virus?
You don't, but they, I think, are kind of like the amoebas, is that they have to have a world where they're all kind of friendly and together rather than, it's not one thing, it's all of them working together. The viral infections are particularly virulent. You think, you would have no trouble figuring out somebody was severely infected. That must be that.
Check one. If you have a question for Dr. Kennedy,
Oh, we have a microphone.
we have a microphone right here.
That's the
So just let me know.
great David Warwick. He'll give you a microphone and ask the questions because I got the answers.
Sarah's got a question.
You can't see viruses under the microscope is the deal. We just have to assume that they get nuked when the bacteria are nuked.
Thank you for your amazing lecture. It was very nice. I have a few questions and also a comment. First of all, when you use the iodine, that doesn't cause any sort of staining, like long-term staining in patients?
If you have dental fluorosis, it'll turn your teeth kind of orange. But it doesn't really. There is a clear form of potassium iodide that is clear. The iodine, the metal itself is orange. If you had to dig it out of the ground and look at it, it looks orange. But there are various forms of it, and potassium. There's iodide. Potassium iodide, I think, is clear, and you can. But I haven't had any noticeable. Some of the old composites will stain yellow, and you put a little pumice on the rubber cup and go buzz, buzz, buzz. It's gone, so it's not a big deal. And it's you know how to clean teeth. Zip.
So when you probe for a baseline, you do the irrigation prior to that?
Yes, I insist on it. Is that when you take a sharp instrument and poke it through some of the most infected tissue on the body, and when you think you're touching at the bottom of the sulcus, you're not. You actually have gone. That sulcus is compromised. That's not a healthy sulcus. That's why you're probing, and you actually go down. They did a study where they were looking at dogs, and that the probers would probe between 1 to 3 millimeters beyond the bottom of the sulcus. And there was one hygienist I had to yell at her that she had been taught to do what's called sound the bone. And so she would poke until she hit something hard, which probably was the patient's fist. Ah, what are you doing? So I want people to come back. I don't need to know where the bone is. I need to know where the gingival attachment is. And because healing occurs under that. People say, oh, the bone won't ever go back. I have an email I sent out about a quadriplegic guy, a patient. He rolled into my office literally, broke his neck when he was 17, and he was a severe quadriplegic. He had fists, and he could move his forearms and his elbows, but he could not adduct his hands. He could not get his hands together. There was no adduction on his hands. And so his teeth had not been brushed since he broke his neck when he was 17. He was 34. And all of them were wobbly. You could have pulled every tooth in his head with your fingers. Pus was coming around all of them. And that the VA wanted to pull out his teeth, and he said that he'd lost so much in his life, it was the only thing he could still grip with. He could grab a pencil and turn a page in a book and so forth by moving his head. And so he refused, and then his parents paid for me to clean him up. And he only took, I think we cleaned him up 6 times. And my program is to clean him up and look, and I didn't see him again. So I cleaned him up, and he rolled away, and I didn't see him for 7 years. So he's 41, he rolls back in, and he came in for a bug check. And I went in, took a sample, and over the microscope and looked at the bugs, and it was perfect. And there wasn't a speck of plaque anywhere on his teeth, and that there were no germs or crawlies, nothing moved. It looked just ideal. And these wobbly teeth that had pus, every single tooth had pus, no more pus, gums are pink, and none of the teeth were wobbly anymore. They had drifted all out of shape, and they were now solid now. I said, you want me to get the orthodontist to pull them back in line? He says, I don't want you to touch anything. And I said, boy, that caregiver, she must be doing a great job on your teeth. And she says, oh, those ladies come through my life like a cloud through the sky. And I said, well, who's irrigating you now? And he says, nobody. He said, I just use that Interplaque toothbrush. It's no longer made, but anyway, he'd worn out 8 of them. And he pointed out that it works for 2 minutes, And so he would aim it at the bass technique, and if you're ever familiar with the interplaque, it had like 8 tufts, and they would oscillate back and forth. So he would grind the 45-degree angle into the maxilla right, and that also is the palatal on the left. And so he'd do that for 2 minutes, and then he'd bite on the head and swivel his hand. He says, I got a grip. I can't undo it. And so they'd pry his hand open and put a toothbrush in there. And he said, and you can push it like this and start it again. So he'd run it for 8 minutes. But because his teeth were spread out like that, that's all he needed to do, because he could drive in between the teeth. Then he said the key, because he understood what we told him. He says, and I'm not swapping spit with anybody. I had a lady that we had her all cleaned up, and she kept coming back infected. And I finally said, "Does your husband have problems?" And he said, "Oh, he died a long time ago." And I said, "Dating anybody?" And she said, "No, not." And I said, "You letting the dog kiss you in the face?" And she said, "Oh, little Pookie." And I said, "You know what he uses for toilet paper?" She quit. And I never finished my story about the 29-year-old lady, the lawyer. And we cleaned her up, and she looked fine. She came in for a post-checkup, and she came up and she said, well, you know, since you say it goes from mother to child, could my 5-year-old son be infected? I said, oh, children, they're so resistant and abundantly healthy, and they couldn't possibly. She said, would you look? And I said, is he here? And she said, yes. I brought it back, and he was full of spirochetes, and just like Mom, and we treated him once, and they never came back. So, you know, Mom had infected him, and we got him at age 5, and we're done. So, mothers, lovers, and dogs.
So I read a study just recently that states, it's actually by a dental anthropologist, that says refrigeration is the reason that we have so much crowding, because our diets have changed to soft refrigerated meat, whereas before we used to have cured meats and jerkies and nuts and seeds, and all those masticatory forces would cause the teeth to actually be correctly placed in order for them to have proper occlusion. And once refrigeration was found, basically, as when the second generation after refrigeration started experiencing crowding, not even the first, it's basically, it skips a generation. So I could find you that study just because you were writing that food for thought about fluorination. I thought I would bring it up.
Interesting. That's what we call a theory, and that John, if you looked at tooth decay declined rapidly. If you had a long enough graph, you would see that tooth decay was really high in the Depression, and even before. But it peaked. It actually went from a slow burn to a high burn, and then it started down about 1950. And John Calhoun's theory on the refrigeration was that the advent of rural electrification allowed refrigeration in New Zealand and other places like Kansas, and that by having nutritious foods in the winter, that you were able to raise your blood level of vitamin C, and that reduced periodontal disease, tooth decay, and disease. So while the dentist is pointing to refrigeration as a possible cause of crooked teeth, that tell them look in the mirror. Now, in China, there were no crooked teeth in the low fluoride area. So they didn't have electricity in either area. So they haven't got the rural electrification. So it's not the electricity, so the refrigeration. So more questions. Everybody got to really fully understands this?
And don't forget those evaluations, please. Everybody kind of fill those out and turn them in. Maybe I can set a record of getting more than 2 that I got last time.
Well, David just asked me what beers do not have fluoride in them. And so the answer is that Yingling, Sierra Nevada Pale Ale, Murphy's Stout, and that's about it.
Are you going to include that as a slide?
Organic wine.
And kokanee.
You guess what?
Dr. Kennedy, my name is Craig Summer. I have one more question for you. Right over here.
Okay, hi.
How about diode lasers, say 980 diode laser as a disinfection method? What's your experience and or opinion of that?
Okay, my disclaimer is I didn't own a laser. So, but the physical problem with a laser is it only goes in a straight line. So you have to be able to somehow get around. It's like if you think of the tooth as basically in a 360 degree circumference around that entire tooth, all of the clavicular fluid is going to have your amoebas, your spirochetes, your small and large gliding rods. So wherever you nuke them, it'll be fine. But it's just like, if you saw the Tom Cruise movie where the end of the world, where the monster would come down and disintegrate people. Well, if he happened to be behind the building and not get disintegrated, then, he comes out and crawls away. So from the standpoint of being able, where you can get to it, it's probably a fine way to nuke things.
In our experience, what we're seeing is if you use what they call an uninitiated tip, it's been cleaved off at 90 degrees to the fiber, and you shine it down in a crevice, you can see that it lights up a lot of area. It spreads out. It's not just totally linear and coaxial with the fiber itself. And I just wondered if anybody else has been looking at that and going through the microscopic analysis afterwards. I don't have a microscope, but I'm wondering whether or not that would be a good thing to employ at this point and evaluate my technique.
I would love you to get a microscope and take a before and after the next 10 patients and then let them wait. Here's the deal, is that anything will get rid of them real quick, salt water or whatever. And then the question is, they actually crawl back out of the woodwork because we actually physically cannot get into all the nooks and crannies where they are. And that's why I like solutions that can flow and get in there. But blast 10 of them, wait 2 weeks, have them not brush, floss, or irrigate on the morning of that visit, give them 24 hours for the critters to grow back up. Because some people in my practice got so good that they would irrigate real like crazy before they came in for a check. And I said, well, that's kind of like shooting yourself in the head. I mean, you want to know what grows up, not what didn't grow up. So don't irrigate, and then we'll see what grows up. So do it and look. It's just as simple as that. And then send me 10 before and after slides, and I'll make a YouTube video for you. And put your name on it, too.
That's the AGD code y'all need up there.
BFD.
Where does something like oral DNA testing fit into your protocol?
It doesn't at all. The reason, very simple, is you can watch on one of my YouTube videos, actually it's on the Price Pottinger Foundation, is a picture of Hal Huggins. And that, remember I showed you that tooth that was completely full of organisms? If you took that tooth, smashed it, and measured the DNA in there, you will find the who's who of bad things. But because there's the DNA of a spirochete doesn't mean you've got a spirochetal infection. And so the mere presence of an organism, and that's what the DNA is going to show you, does not tell you what the primary infectious organism is, doesn't tell you the presence of white blood cells. I can look at a slide and in 10 seconds tell you, is this person an active periodontal case or am I just looking at a bunch of bacteria? Because if there's an army of white blood cells moving through the screen, they're fighting something. Whether the question was about amoeba earlier, whether it's the amoeba or whether it's the virus or whatever, if there's an army of white blood cells, there's an infection going on. And when there's one security guard sleeping in the kiosk, then everything's okay. So you can have an occasional white blood cell, that's what they're doing, they're patrolling, and that's okay. But you don't get that information from DNA testing. You get the different names of the organisms, and it's a good research tool. It's hugely expensive, and so hugely expensive for a minimum of information. If you I got $25,000 worth of microscopes for $5,000. Some idiot dentist bought 2 beautiful phase contrast video microscopes, a 30-inch display, a microscope display. I mean, not a TV. This is high def, with video cameras, Ikegami video cameras, and state-of-the-art recorder and all that stuff, and made all the lease payments up for two-thirds of the way through, and he's down to $5,000, and he'd never taken it out of the box. Don't think mercury bothered him too much. Anyway, I got that nice setup, and there are closets full of microscopes. Bill Landers comes to the meeting. He has got a really good $3,000 microscope. I've got a $150,000 airplane. Why can't you afford a $3,000 microscope? It's just they're just and once you have one, you feel naked if you don't, because it's just it answers the question: is it ongoing or is it? See, we were taught to use a sharp ruler to see if gum disease was going on. And back to Bob Barkley, that's like using a ruler to see if your house is on fire. That's a little shorter on this side. Because it burnt one time in the past doesn't mean it's on fire. But if you go in there and there's full of white blood cells, it's on fire. Because that's your army. So if the army's out there working to fight something, our job is to figure out what they're fighting and get rid of it. You can see an army of white blood cells if the person's coming down with a flu or a cold or something like that. So that's not written in stone. But if you consistently find too many white blood cells, then they're fighting something in the way of an organism of some sort. And but I'm down on expensive ways. Because the cost of a microscopic slide is about 10 cents. And so what I did is I made a routine. Everybody in my practice got a bacterial smear at every cleaning appointment and every new patient exam and every recall exam. The hygienist would usually take it, and then I would see them. But every year, at least, we looked at the bugs, and because there's no reason not to. It's a 2-minute procedure, and the patients would come in and they'd say, "Oh, let's do a bug check." And she had her microscope in her room, and I had a microscope. And she'd take a sample, and they'd go over and, "Is that the bad kind?" And they'd know. They quickly identified the bad kind and learned how to kill them. Please.
Say you purchased a microscope, where do we get training a little? If you had no experience with this procedure, where would we get some training as to interpreting the results? I mean, you know what you're looking at, but
I do know what I'm looking at, and it's really, really simple. If it moves, kill it. But one of our members, Oksana Swack, was in the room earlier. I thought she's waving in the back. Oksana puts on courses. Another member of our perio committee, Tom Baldwin, puts on courses, or used to anyway. So the other thing is that the modern microscope is what's called a video microscope, and that means that if you've got a nice little laptop like this, it's got a high-def camera with a USB connector. You connect the little USB connector over here, and you push record, and then you've got a little recording. You can stick that up on YouTube and send it over to me, and anybody else can look at it. And I got to tell you about my friend Jim Knott, the guy that made me get my microscope. And Jim looked under the microscope all the time. And so when the business was a little slow and his dental assistant came back from lunch and he said, "Let me look at your plaque." And he'd done that 100 times before, but anyway, he went ahead and looked at her plaque, and she about jumped out of the room because there was this snake that basically extended from the left-hand field of vision, undulating all the way across, clear out the right-hand field of vision, and it was enormous. And she was like, "Wah!" And so Jim pushed record on that. He didn't know what the heck it was, and he sent it off to Siri Bhaskar. Siri Bhaskar was the Surgeon General dentist, the Surgeon General of the U.S. Army, and he became a periodontist in Monterey, and he sent it off to Siri. And Siri said, "Oh, that's not from the mouth. That's out of lettuce. And then I've seen those in lettuce and vegetables." So Jim went back to his dental assistant. "What'd you have for lunch?" He said, "I had lettuce. I had a raw salad." He said, "Oh, well, you get a little protein with your salad."
Any more questions? All right. Thank you, Dr. Kennedy. That was great. We've got one more. We have one more short video to show you. It's about the accreditation. I mentioned it, I think, this morning. But one of the advantages of becoming accredited or becoming mastered, we do a taping. Now, we have started this. Is this on? Okay. We started this in Charleston meeting in last March. We started the idea, and then we actually did this in Vegas in September. But what we're trying to do with this is it's a way for the master or accredited member to put this on their website so patients or anybody coming in can see that you are accredited. So it's just a little bit more marketing. It just takes maybe 10 seconds as soon as we get it running here. Thank God for Dave.
Oh, we got all that stuff give away.
Just check that, 4, I think.
Oh, no video, no audio.
It might be muted.
Good job.
It's, okay, I got it. Sam.
Hi, I'm Dr. Bill Virtue, President of the International Academy of Oral Medicine and Toxicology, the most highly regarded biologic dental organization in the world. It is my pleasure to introduce to you Dr. Joe Palmer of Greenville, South Carolina. Dr. Palmer has been practicing biological dentistry for the past 20 years. The Academy is very proud to announce that Dr. Palmer has successfully completed all the requirements and shown proficiency in the practice of biological dentistry and is therefore awarded his fellowship with the Academy. Congratulations.
Thank you, Bill.